Hello everybody, I'd just like to welcome you all to tonight's webinar from MHPN, Collaborative Care in Mental Health and Diabetes. This is an interdisciplinary panel discussion. This webinar is co-hosted by Diabetes Australia Vic and MHPN. MHPN is a Commonwealth-funded project supporting the development of sustainable interdisciplinary collaboration in the local primary mental health sector across Australia. Diabetes Australia Vic is the peak consumer body and leading charity representing all people affected by diabetes and those at risk. It is committed to minimising the impact of diabetes in the community and helping all people affected by diabetes and contributing to the search for a cure. The panel tonight are four. We have Dr. Ralph O'Dem, who is a GP, Melbourne-based GP, who's been quite involved in divisions of general practice and community health since 1994. He has a 20-year experience in managing diabetes and mental health problems. Catherine Picillo is a diabetes educator based in Melbourne. She's been a diabetic nurse educator for almost 10 years. She has worked in community practice and most recently is working with Diabetes Australia Vic as a consultant. She has wide experience. Professor Praseena Reddy is director and a health psychologist based in Newcastle. She's director of the Centre for Rural and Remote Mental Health. She has experience both international and Australian, particularly in behavioural medicine and the clinical links between depression, heart disease and diabetes. And lastly, we have Professor Tim Lambert. Tim is Professor of Psychiatry at the University of Sydney, Concord Repatriation Hospital, and the Director of the Concord Centre for Cardiometabolic Health and Psychosis. Tim has vast experience in the management of schizophrenia, in atypical psychotics, and in the metabolic sequelae and comorbidities associated with mental illness. I am very pleased to welcome all four of these talented people to our webinar tonight. The learning objectives for this webinar are threefold. At the end of the session, participants will have an improved understanding of the bi-directional relationship between diabetes and mental health. They will be able to identify the role of different disciplines in contributing to the screening and diagnosis, assessment and treatment of mental illness in people with diabetes. And they will have tips and strategies for interdisciplinary collaboration in supporting people with diabetes and mental illness. To find out more about your particular discipline CBD recognition for tonight, please visit www.mhpn.org.au. I'm so looking forward tonight. We have such a talented panel on tonight. It will be in two parts. The panel will initially present for 2 or 3 minutes their particular segment of tonight, and then we'll have question and answers both within the panel and questions that you in the audience post in that lower section on the lower right-hand side of the screen. We would be very keen for you to interact with us during the evening by texting into that section. There's some ground rules. I will moderate the panel discussion and I'll also field the questions from the audience. As I said, please submit your questions. If your question isn't addressed, don't worry. You can continue this discussion later on and participate in the post-webinar online forum on the MHPN online. Please ensure that your sound is on and that your volume is turned up. And if you are having problems with sound or with technical problems tonight, please dial that 1-800 number that's on the right-hand side of your screen. The webinar is being recorded and also the PowerPoint slides will be posted on MHPN's website within 48 hours of the live activity. So without further ado, everybody would have seen Bruce's history. We will now pass over to Ralph to discuss this case. Thank you, Ralph.
Good evening, and thanks for inviting me to participate. Mind you, the case study that you presented is actually quite a challenging one, and certainly some of the things that would really raise concerns for me is that he's a middle-aged man who's recently divorced. He's had some significant stressors with, his son going to jail with armed robbery. He'd had to shift out from his, normal area and possibly lost some of his, network of friends or contacts. And his new partner has noticed a significant change in him. And so, for me, one of the things that I'd be really concerned or worried about is his risk of suicide. So that's something that comes, roaring out at me. But there are a whole lot of other things as well. He's a long-haul driver, so you wonder whether he's been using other drugs, whether, illicit drugs or drugs to keep him awake and vigilant, whether he's been using a lot of alcohol lately. I mean, he's looking unwell when he comes in to see me, so, that could certainly explain some of it. And so, certainly, the initial approach here is finding out, how Bruce is actually tracking, and by reflecting back to him just really what sort of a tough time he's had over the last few years and how he's actually coping with that or tracking with that, how's he actually feeling within himself. And, certainly one of the challenges that we've got with Bruce is that we normally book a double appointment for a new patient within our surgery. Clearly, what's on offer here is going to clearly exceed that because not only with the changes that he's had, he's also got diabetes, and so I need to know all about his other past conditions. Certainly, with people with diabetes often have a lot of other comorbid problems to do with heart disease, hypertension, and so on. I need to know all his medications. At the moment, we're only told that he's on metformin. Now, he's had diabetes for 7 years, and he's still only on a fairly a moderate dose of metformin, but that's all. Usually by about 7 to 8 years in someone who hasn't made terrific lifestyle changes, often we're talking about having gone through 2 or 3 medications and thinking about insulin. So I'm really interested to know what his control is like and where he's been. And so on regards to that, he needs to have what I'd call a full assessment, which is both a full history and a full examination, which is really a top to toe. And clearly, I'm not going to be able to do that in my, double appointment for my initial one. So certainly, I do need to rebook him. But some of the things that, he's in his 50s and he's looking unwell. So, certainly apart from the suggestion he may have a mental health issue, there are a whole lot of physical things that we also need to take, be aware of. Things like, could he have cancer? Could he be feeling tired and down because he's had blood loss and he's anemic? Certainly with bowel cancer, he's a typical age group to get it. And, he's pallid, so, some conditions that we know can cause diabetes, like hemochromatosis, and that will certainly cause people to look really grey, and it can cause liver, and it can cause heart problems. So you can see that seeing him for the first time is actually bringing up quite a lot of questions. And I'm not going to sort them all out in just one visit. I mean, even other things like he's on a 3 times a day dosage of metformin. I can tell you that the compliance on 3 times a day is really poor. So I suspect he's not even taking that. And I just wonder, you can see that with all this information that I want to get to, it can almost sound sometimes like a Spanish Inquisition. And so sometimes balancing the questions with letting him respond and giving him some time to take it where he wants to go can be a real challenge because, obviously I've got time limitations. He wants his agenda sorted out. And so you can see that there's going to be quite a few visits that's going to need to happen after this to get a real handle on him. Certainly he will need a whole lot of pathology tests, looking for underlying physical conditions. And normally I would rebook him within a week or two to follow up on those results. And we're lucky enough that we have a pathology nurse within our clinic, so certainly at the end of this consultation, I'll be taking him straight there and getting the blood test done there and then. And I can do that for two reasons. One is to make sure that they're actually done, but it also gives me a reason to chase him up if he misses his next appointment. Because, I mean, I've only ever met him once. And with, again, the follow-up appointment, it will be another long appointment. And if he, after my inquisition, still agrees that he wants to stay with me as his GP, certainly I'd be offering him an hour appointment with me and my nurse to go through a whole care planning process. Now, a care plan is an item or a process that we can use within general practice that I suppose allows us to understand someone in a little bit more detail, because we're given time to work out what their major issues are, and we can negotiate where we think and they think they need to go, so you can come to a common understanding. And one of the good things about it is it's all documented and everyone gets a copy, so we've got some shared understanding of where we want to go. And I certainly find those incredibly useful. And within that time, my nurses can certainly be screening for things like depression and other issues as well. And certainly when they come and see me, I can then be following up anything that was then, found on that in that process. But certainly, a lot of males, I'm being a bit sexist here, but certainly don't like to have all these visits with the doctor. But given the fact that he's a long-haul driver and a commercial driver, I can certainly make a good case in that we have to keep him healthy and so that he actually keeps his licence. And that's a real issue for people who have diabetes and, in fact, drive on commercial licence. They do have to look after their health and keep well. And as I said, if he does miss his appointment, when I get the pathology results, I've got a very good reason to chase him up, whether they be normal or abnormal. At least I can follow him up. And I'm suspecting that we're going to see quite a lot of abnormalities in his test. And then it's really out of the initial visit and then the follow-up visit, depending whether it's a care plan or even just another double visit. It's then following the pathway that we both come to, that we both need to address. And obviously there are going to be some big issues that I need to deal with around the drugs and the alcohol, and whether in fact he has depression or not. And certainly, it looks like he may have that, but there may be a lot of other things going on. So, and that's where I'd probably leave at the moment, because we don't have a lot of ongoing information. And certainly this is one thing about general practice, is that in patients that we normally see on a regular basis, you have more than one bite of the cherry. They keep on coming back, so you don't have to solve everything all at once. But as long as you have an agenda that you can prioritise. And certainly we would be setting an agenda with him and working out what we need to tackle first. So that would be it from me.
Thank you very much, Rob. That was a very insightful presentation, and I'm sure our panel and our audience will have many questions for you. Next, we'll just move on to Prasunna. Would you like to give your presentation, please, Prasunna?
Yes, thank you. Are you able to hear me all right, sir?
Yes, you're coming through loud and clear.
I approach this, I think what I would do is have a conversation with Ralph. And I'm assuming that Bruce would then have come to me as a psychologist. So I'm going to take it the next step and think, what is it that I would be looking for in a first consultation with someone who has been referred to me, and let's assume that Bruce has been referred. What I find very useful in working with people who have diabetes is a pyramid model which looks at different levels of distress and then works out from the evidence base what might be the best intervention. And I've given you a reference for this, which is written up in the NHS documents in Diabetes UK. So essentially, if we look at level 1, this is general difficulties in coping. There's a range of emotional and psychological needs of people with diabetes. And in level 1, we would expect general difficulties coping with an initial diagnosis and the day-to-day reality of living with diabetes. Now, about 60% of adults with either type 1 or type 2 diabetes will report at least one troublesome emotional concern related to diabetes. And the common kinds of concerns are feeling scared and angry about having the condition, worry about future consequences, feelings of guilt and anxiety because self-management is not as good as it should be, feeling deprived of food or concerned about eating, resentment about the pain and inconvenience associated with glucose monitoring, injecting, resentment about the impact of diabetes for the remainder of one's life, and the notion that it is 24/7, it is every hour, every day. There's often frustration at unpredictable and high blood glucose levels, and especially early in the phase, we could get fear associated with beginning insulin therapy, the complications involved. For some people, it's also combined with an unhappiness with the patient-health professional relationship and so on. What I'm thinking when I look at the case of Bruce is the diagnosis was 7 years ago. I don't know how well his diabetes has been managed over those 7 years. It's interesting that he has not been in touch with his GP, and in the new relationship, he comes to see his partner's GP, not his own. So I don't know what happened in the previous relationship and why he might have left that previous GP. But assuming that Ralph is the GP whom he's seen, then in a handover, I'd be asking, tell me what you think. Tell me what you believe is happening about his management of his diabetes, because I don't have that information. In terms of level of risk, I think he's beyond level 1, and I'd be thinking about level 2. And in level 2, the issues are less prevalent than those at level 1, but there would be more severe difficulties in coping. We'd expect greater anxiety or lowered mood and some impaired ability to self-care. So the kinds of things that suggest he might be level 2 are the smoking, the overweight, the complexion, the tiredness, fidgeting in the consultation. Again, we don't know how much of that is because of the diabetes, how much is related to the management, how much is related to a fairly serious issue, which is to have a child that's charged with armed robbery. A substantial stress for anyone on top of a relationship breakdown 18 months ago. So it could be that there are a whole lot of crises, and what we're seeing is the impact which we might attribute to diabetes or diabetes management, but it could also be these other issues. If we're looking at a level 2, generally people at level 2 are don't have a diagnosable clinical condition. They will be psychologically low. They will report symptoms of anxiety and depression. And assuming that it's a level 2, the kind of treatments we would be looking at are your usual interventions for severe difficulties in coping with anxiety, distress, so it would be cognitive behavioral stress management, antidepressant therapy, and then issues to do with specific areas of concern. So level 2 is manageable through psychological therapy. If we go to the next level, which we might consider, and these are psychological problems that are diagnosable and can be treated through psychological interventions. So we're still not at the stage where we're thinking of bringing in a psychiatric consultation, but there's levels where we might go there. I think we could well be dealing with a level 3 with Bruce, Emotional and psychological needs at this level might be treated with psychological intervention. They'd be mild and moderate cases of depression, anxiety states. They also get obsessive compulsive disorders at this stage. And attitudes towards eating behaviors. Insulin therapy, we know, is associated with weight gain, may contribute to a negative body image. There's weight management problems. And again, it's not surprising that given the level of stress Bruce has experienced, we might be seeing an impact of that. I'm interested in that alcohol is not mentioned. I would have thought that there would have been an assessment of whether alcohol is used as a coping mechanism here. If it is a level 3, then the evidence base suggests that both individual and group psychotherapy leads to benefits. There could be issues about relationships, especially with healthcare providers, significant others, metabolic control that we could help with, integrated inpatient therapy with behavioral training often helps, but again, it's really good to have a team, and doing this work on your own as a psychologist is not as easy as working closely with the GP, the diabetes educator, or other health professionals who are involved in the care. And finally, a level 4, which would be a more severe psychological problem that requires biological treatments, medication, specialist psychological interventions. I'd want to talk this over with the GP and say, tell me what you're thinking, and how could we work together in this case. Level 4 would be major depression, and if we did think that it was major depression, then I think it would be useful to do a diagnostic interview. We know that people with diabetes are twice as likely to have clinical depression compared to the general adult population, irrespective of the type of diabetes. And the prevalence is about 6 to 14% at this level. I've been looking at some data recently that compares people who have type 2 diabetes with and without insulin and type 1s, and the type 2 with insulin therapy are the most distressed across the 3 groups. And are they more distressed in terms of quality of life, in depression, anxiety, and other issues that they report? And I find that an intriguing question, and I think we need to understand more about that, what it is about that group who are on insulin that leads to this distress. If we were looking at Bruce at level 4, then we would have to consider both biological treatment and complex psychological intervention. I don't know whether there is an anxiety disorder in addition to the depression. I don't know whether there is suicidal ideation. So all of those things are better discussed in collaboration with the GP, and if we're fortunate to have a psychiatrist available to have that discussion as well. And finally, level 5 would be the severe and complex mental illness that I think Tim will be addressing, requiring specialist psychiatric interventions. For instance, if we were looking at bipolar disorder or eating disorders at a severe level, then we might look more carefully at what this is. From the evidence I have here, I don't think Bruce is at that level, but I'd be thinking about certainly level 3 and maybe level 4. I've finished my presentation, Michael.
That's lovely, Priscilla. Thank you very much. That was a great presentation. We'll come back and discuss that with you later. I'd just like to move on now on to Catherine, who's going to talk to us from the point of view of a diabetes educator. Catherine.
Thank you, Michael. Well, first of all, Ideally, we would have a referral from a GP when we see someone, so that we can have some pathology results. So ideally have an HbA1c, which would indicate their level of control, so how high their blood glucose levels have been over a 3-month period, and hopefully to compare previous HbA1c over the 7 years of diabetes, if possible, would give us a bit of an indication as to whether he's progressed, whether he improved in the beginning and then deteriorated, and whether it coincided with his marriage breakup. Usual pathology, lipids, so cholesterol, which may be likely, to have kidney function, urine microalbumin, and then any other relevant pathology that the GP would have done, and most of the time.
Catherine, excuse me, may I just ask you just to adjust your microphone a little bit?
Sure. Can you hear me now?
That's much, much better. Thank you very much.
Yes, thank you. Sorry.
No, you're fine.
And any relevant pathology that the GP would have done, and usually they do thyroid function, hopefully vitamin D, which has been associated with seasonal affective disorder and tiredness, and perhaps even vitamin B12, which people on metformin for a long period of time can be deficient in, even though it's not common, and they may have signs of depression and memory loss. So just having a general pathology and then relevant medical history from the doctor and any current medication, including complementary therapy, vitamins, and over-the-counter medication. And prior to the appointment, we would request that the patient bring in all his medications and that he bring in his blood glucose meter and monitoring diary for review. And often this can give us information. So if a patient tells us that they don't have a blood glucose meter after 7 years of diabetes and being on the road commercially, that would be a bit of a concern because it would tell us he's not keeping track of his diabetes, even though he doesn't seem to be, he's not on any medication that could cause low sugar levels at this stage as far as we know. In my experience, when I've seen truck drivers and people with commercial licenses, because this is their livelihood, often they won't take medication that they feel will lower their sugar levels and risk their chances of not driving, so and losing their license, and so they may not take medication that the GP has prescribed for them, and so this gives us a bit of information. And also, like Ralph, I've made a few assumptions. So, type 2 diabetes is a progressive condition, and I would expect someone, again, a generalisation, perhaps he's a truck driver, perhaps he hasn't taken care of himself so much, he's overweight around the abdomen, probably not having doing a lot of activity or making the right food choices. And so I would have expected that his diabetes has progressed by now, and perhaps he was on multiple anti-diabetic medication and perhaps on his way to insulin. So that would be interesting to see where his glycemic control is, blood glucose levels, whether they're high. On initial assessment, of course, the observation, so how he entered the room and whether he turned up with his partner, because I have to keep in mind that he probably didn't initiate this appointment, and so we need to tread carefully so that he does return and doesn't feel that perhaps his partner is trying to bringing him against his will, and that we're not imposing too much information on him. Looking at current signs and symptoms, so if he's got signs and symptoms of high sugar levels, such as thirst, urination, and whether he's actually uncomfortable with these symptoms, which could be getting him down as well. Past medical history, so if he does have, for instance, thyroid function problems or other issues, and then whether he's had complication screening. So it would be a tick box sort of thing at this stage, so has he had his eyes checked and so on. and whether there were any existing complications from diabetes, and that would include erectile dysfunction. Often the first time that we see men who've not seen a diabetes educator before, the first time we do see them is because they're experiencing erectile dysfunction or some sort of depression, and often they want to talk to someone, and they don't know how to broach it. So these are the subjects that we do bring up at every consult, and then asking him about physical activity, how much and how often, and the type that he has, if any, and some food choices and patterns. So we imagine that being a truck driver, he would probably have a lot of takeaway food, probably wouldn't eat for hours and then eat large meals at some point, and so on. And then sleep patterns, of course, that would go hand in hand with his driving. Often, as Ralph said, they do have long hauls. You know, some truck drivers have told me that they've done 18 hours straight, and that was forced upon them by their employer. So often there are difficulties, and they're afraid that they will lose their jobs if they don't attend to that. So there's a combination of issues with sleep and perhaps asking about alcohol use, how much, how often, and whether there's any binging there. And that would be an issue if he was drinking whilst he was driving as well. And the smoking, we know he's a smoker already, and it would be how much and how often, and whether he's tried quitting and whether he's interested in quitting. So that would be an issue too. And we know that most people will try 7 times before they successfully quit, so we could discuss that as well. Screening for anxiety and depression, I put a question mark there because, look, it's not something probably that is widely done in the diabetes education community. It is done by individual diabetes educators. Not sure that everybody does it. I don't know. We haven't done research in that area in terms of asking every diabetes educator. I imagine that there are some. I know some diabetes educators are doing it very successfully because they have a good support network, a psychology team at their work, and therefore they can refer on very easily. I know that in our DAPHNE programs, which is a Type 1 structured program, we administer the PAID and the HADS to all participants, and this allows us to broach the subject of anxiety and depression and any issues that they're dealing with diabetes. And then, of course, performing function tests on their blood glucose meter. If you did bring in a blood glucose meter, check the memory of the meter. Often people will tell us that they're monitoring, but not. And often they tell us what we want to hear. And it's mainly often because they either think that it's going to be a lot more difficult than they think, or that it's going to bring a lot of time-consuming effort. So doing a function test, making sure that they're using their meter correctly, assessing the accuracy of their technique, and making sure that they are testing. And then hopefully that they would be recording their results so that patterns and trends can be obtained. And obviously, if I got an HbA1c and the HbA1c was within limits or just slightly above recommended range, then I wouldn't be so concerned. He's only on metformin, so there would be no risk of hypos. So it could be that, depending on what's happening at the time, how the consult would be directed. Check current blood glucose level, especially if he didn't have a blood glucose meter or he didn't test often, because often that's when you are able to pick up that their sugar levels are very high, and discuss that at the appointment. Check current blood pressure, because we know that people with diabetes, often type 2 diabetes, often have high blood pressure and are often on medication, and of course this also involves the kidney, so high blood pressure can impact on the kidney, so it's very important that we maintain a good blood pressure. And of course inspect and assess feet. I've had truck drivers tell me that they don't have sensation and can't feel the pedals under their feet, and this is a really important assessment that needs to be done, which includes a 10-gram monofilament exam and pulses and so on. And that doesn't take very long for a diabetes educator to do. I would also ask what previous allied health referrals have they had? Have they seen anybody? So would Bruce have seen a diabetes educator in the past? And if he hadn't, then perhaps that's why he didn't have certain things in place, like a meter and so on, or maybe he had and decided not to, or maybe he's using his meter at the moment. So not sure. Has he seen a dietitian, which would help him with his weight and food choices, podiatrist, and to make sure that his feet are being looked after. Exercise physiologist, perhaps, to support him with weight loss and insulin sensitivity, to improve his insulin sensitivity. And because he has a commercial license, I would expect that he'd be seeing an endocrinologist because by law they need to have yearly forms completed by their endocrinologist if they're using a commercial license. And then, of course, a psychologist if he's seen a psychologist in the past. And then discuss some safety information, which often people don't know about. So has he informed Vic Rhodes of his diabetes status, whether he's on insulin or not? All people with diabetes need to inform Vic Rhodes. Has he informed his employer of his diabetes status? And again, it's not always compulsory to inform your employer, but it would be a valuable thing, especially since he's driving a commercial license, and often this can impact on their insurance. And so if you explain to people that they may not be insured if something happens and it's discovered that they have had a hypo, not that Bruce is at risk at this point if he's only on metformin, but if you explain these things, then they may take them a bit more seriously. Regular eye and vision checks are really important if he's driving. So does he have retinopathy, or has he got blurred vision due to high sugar levels, which would affect his driving? And once again, this comes to his fear of losing his license and his livelihood. And, of course, reviewing vision during times of elevated blood glucose levels so that he gets monitored. Regular foot checks for sensation, regular heart checks because he's at risk of heart disease and, whether he's getting chest pain at the moment, especially during driving. And, of course, monitoring before driving. Again, he's not on a medication that could cause low sugar levels at this stage that we know of, but he may. So the key messages really is that self-management, especially with concurrent mental health issues, requires ongoing team support. And when caring for people with diabetes, issues of safety, personal and community must always be considered, especially when they're driving a commercial vehicle. And that the progressive nature of diabetes means that management is progressive and lifelong, and often, as Priscilla said, no one gets a break.
Thank you, Catherine, for that presentation. That was a very good presentation. Thank you very much. Now, Tim, I'd like to have your presentation, please.
So, what we've seen so far is, some incredibly practical advice. So I'm not going to repeat any of that. I'm just going to give you some sort of little bits and pieces that might help cement the relationship between this particular suggested mental illness and the actual physical health outcomes. If I was to see Bruce with Gustha leteris, we've all seen as part of the actual handout, you'd think mood disorder, certainly. He's got all the usual antecedents of that. The loss is written large all over his life at the moment. However, we've got to think what his profession is, and you don't do 18-hour hauls by drinking alcohol. You are usually using amphetamines. I think my most interesting case when I was in Perth was a truck driver who actually inserted an IV line and sort of dissolved up all his speed into this and just dribbled amphetamines into himself across the nullarbor. Of course, where I saw him, he had become psychotic. So, We've also got to think that for many people who are lonely and isolated, long-distance drivers and so on, they often have quite unusual personalities, but the structure of their existence actually keeps us in control. And so when it's unmasked, they fall apart in a very broad sense, both psychologically and, of course, physically. The two are not somehow separable. So underlying all of this, obviously the substance abuse is there, but I'm not going to focus on that. Let's just say he's got depression. Without even having to think about it, we would expect about 1 in 5 men and perhaps 1 in 4 to 1 in 3 women who've had established diabetes will have significant depression at some stage. The trouble is, when people have had diabetes and with comorbid depression, the symptoms of both tend to become blurred, of tiredness and all the rest. And one of the big problems, of course, is that depending on your label that's been attached to you, here's Mr. Bruce, and he's got depression, and the rest of the, period of care will be focused on his depression and not his physical health, and vice versa. So one of the big problems we have is that that not so much in depression, but in the more severe mental illnesses. At this present time, there's a 25-year loss of life due to premature cardiovascular mortality, and this comes about usually because people just really haven't had their physical health needs looked after. So we know that in those with depression, where there's still a lot more chance that they'll ask for help, but they may not, again, give the cues to say, look, I've got 2 sorts of disorders going on. And it is actually quite rare to find people who are thinking about both physical and mental comorbidity. Now, we just, I guess, need to know that the outcomes are pretty bad when you've got both. And I'll show you some of those in a moment. Now, it says he pressing the button on his computer, which won't work. Here we go. One of the things that interests us, although our centre is a big multidisciplinary centre with people from most of the allied health areas and quite a few medical specialists, and we sort of trying to chart the breadth and depth of the relationship between premature cardiovascular death and mental illness. But in the case of depression, over the many years that many people have been looking about it, there's no doubt there is, to a lesser extent than there is with psychosis, premature death from cardiovascular causes. And when you look at trying to model this in multivariate modeling, what you find is depression is often mediated by chronic conditions of any sort. So everything else in your explanatory model sort of drops away, and you're left with whatever this chronic illness is. This is the mediator. When you unpack that a variable, we start to get to the more obvious things, lifestyle. And lifestyle remains an independent predictor, obviously, with food and lack of exercise for the modern man, and of course the inevitable link to diabetes. Now, the diabetes and depression relationship is complicated, and though we've described it in this webinar as bimodal, I'm not absolutely certain the neurosciences do support that at the moment. But once you've got diabetes, well, your chance of earlier cardiovascular death is 300% higher anyhow. So once we've got into this pattern, we should be already saying it's dangerous. Now, let's think about Bruce. He was diagnosed in his early 40s. That means he's probably had significant hyperglycemia since his 30s. So he's now 50s. So he's had probably anything up to 20 years of silting all his end organs up. And, of course, even in people without mental illness, at their first presentation for a diagnosis, about 50% of people have end organ damage. Retinopathy is the most common, but of course we've got to think about small vessel disease that could be more subtle, not only kidneys, and peripheral nerves, but also cognitive functioning. So Bruce, in fact, may be declining in his social and occupational and every other function, yes, because he's got depression and there are obviously neuropsychiatric mechanisms at work in his brain. However, one has also got to consider that he may well have had progressive changes from very poorly managed diabetes with subsequent changes. Just the other day we saw a lady who was 52 who'd had a really unpleasant stroke and had lost the vision in her right eye. This was because she had a mental illness, had been diagnosed for 10 years, but everyone spent all the time focusing on her mental illness and forgot to check her sugars once in 10 years. After her stroke, we saw her, and her fasting sugar was 22. So that's an example. The first presentation is actually a dreadful, almost could be terminal event. A stroke is a complicated, untreated diabetes because the primary problem was, of course, a mental illness. So now, if we look at the relationship between depression and the poor outcomes we can see in diabetes, and let's not forget that by 2020, tax dollar will not really be spent on schools, roads, or anything else, even general medicine. It's all going to be spent on diabetes unless we get control of this sort of epidemic that's arising. Now, we know that, it's very interesting, the description of people over 50 as older. I thought 50 was the new 40. Anyhow, for people who are over 50, we know that they automatically going to increase their risk when they've got depression of developing not only cardiovascular disease, but diabetes and arthritis in the next 12 years where people are followed up, but not cancer. Now, those who've already developed diabetes, and it's progressed to the degree that they're starting to get sort of fairly typical foot ulcers. If you look at the cohort of people who are depressed with foot ulcers versus the foot ulcers people who are not depressed, the 5-year mortality is much, much higher for those that are depressed. Let's look at another very common symptom. People who have diabetic peripheral neuropathic pain, you know, the sort of pain that comes as all your nerves and your peripheries sort of drop off the perch. Now, it can be extremely painful. However, if you're treating depression, a lot of that pain can be ameliorated. Now, of course, the question is, are we actually treating the depression, or antidepressants actually treating the pain through the usual gating mechanisms? But it appears to be an actual depression effect rather than a simple sensory gating effect. So having any chronic illness, physical illness, is a risk for depression. So I think that's a sort of given at this stage that many of us need to sort of try to communicate to our colleagues. Now, if I look at what people are trying to do, there's been this terrible problem for forever, really, about people at the specialists in psychiatry and actually sort of knowing what to do about the physical illnesses. Most of the patients do not have GPs. People with depression might, but in this particular case, the guy hasn't had a GP for a long time. Now, that's not the exception. That's the rule. And for most people with enduring mental illness, you'd be lucky if a quarter ever saw a GP. So it was thought, let's try, not by us, of course, let's try just comparing sort of care as usual. All will go and we'll see these people, we'll diagnose a depression, and we'll write to all their doctors and to them, telling them they need to get treatment and they should be followed up. And what good did that do? Not a cracker, not a sausage. So what it's saying is, it's the problem we've, I guess, been writing about for many years, which is everyone gets very happy when they're screening people for comorbid diabetes. But that doesn't pass the so what question, because the issue is, what are you going to do about it? And so in this study I put out, one of thousands I could have put down, was to remind us, just because we've detected something and we've written a letter doesn't mean it gets better. So we really need to start saying that depression is, because there's a sort of medieval sort of stigma attached to depression, but it's just another biological illness that has psychological and social consequences. We do need to treat it vigorously. Okay, so how would we treat Bruce? I mean, he can have, I guess, we actually believe in group work. We have 3 big clinical research programs in relapse prevention and people who don't get better, and, of course, cardiovascular health and psychosis. The biggest effects we've had are in groups for those with mental illness. Because I think a couple of the previous speakers have mentioned this whole concept of diabetic stress or related stress. It's a real thing, and this seems to be independent of how bad your sugars are. So if you look at the people who are distressed, they don't necessarily have the highest markers for sort of hyperglycemia for the last 3 months. So group work focuses more on reducing the stress. Now, what about for someone who's not easily able to attend any form of therapy, like Bruce, who's in a truck most of the time? After we told him that he has to stop taking amphetamines because it's bad for him, we hope that he will engage in therapy. And because we're moving towards e-learning and e-therapy and e-everything, there's a little bit of research now saying that we could probably engage him in telephone-based CBT and just daily prompts on his mobile to just walk X number of steps when he's in each town that he can actually stop at. Now, in these sort of studies, although the A1C levels don't actually improve very much, the other markers of insulin resistance do tend to get better. So blood pressure goes down, physical activity does go up. And of course, we all know from nothing to do with diabetes that exercise is a very good treatment for depression. So the depressive symptoms fall. And of course, quality of life comes back. And as that happens, the person gets out of their rut of comfort eating and all the other things that often ensue. So my last slide is the slide we use for our team when we usually do full-day education for people around New South Wales with our multidisciplinary team. And here's a list of everyone that we actually think should be engaged in this whole activity of looking after people with comorbid physical illness and mental health issues. And as you can see, and I think I've made it alphabetical, so if you're down the bottom, that doesn't mean anything, except for exercise physiologists, which I added at the last moment. Bless them, bless them. We have such a good exercise physiologists working with us, but anyhow. So you can see dietitians, GPs, medical specialists, nurses, occupational therapists, pharmacists, psychiatrists, probably the most useless part of it, I know, because I'm one of them, and psychologists, registrars, social workers, and exercise physiologists. Every single one of those gets involved in our clinic at least once every fortnight, and most of them all the time. So this is a multidisciplinary, I've been at a university meeting all day talking about this. What's it called? Sorry, interprofessional sort of approach we should have. So that's it for my little formal bit. And as you can see, that's our minimum basic team to deal with this problem. And there's quite a few of us. It is very hard, as one of the previous speakers said, to do this by yourself. Working in teams is almost essential. So, thank you.
Thank you very much, Tim. That was a very, very good presentation. And this webinar is going nationwide tonight. So, people in the regions and in rural areas would certainly commiserate with you. It is difficult to get multidisciplinary teams together, even as you say, in the cities. I'd just like to ask Catherine if she would like to ask Ralph a question. Catherine, do you have any questions for our GP?
Yeah, I do.
And could you just raise your voice a little bit,
sure.
Catherine? Thank you.
Ralph, do you think the GPs and their patients would have enough appropriate resources available to them in their own practice and in the community if GPs screened all people for diabetes, with diabetes for depression?
Okay, so look, there's a whole range of general practices out in the real world, and certainly some practices do this and do this very well already, and some people are probably unaware of the importance of screening for depression within their patients. But certainly, with the advent of some of the new care planning Medicare item numbers, we're finding more and more GPs more comfortable spending time screening and supporting patients in a more coordinated way. And so we have things like when doing care plans that some practices will automatically use a screening tool for distress or depression, and are happy to apply it and then manage it from there on. And of course, even though there's been such a huge hullabaloo over the recent mental health funding, there is no doubt that having access to psychologists for people that we've detected has been fantastic. And that's certainly increased the capacity of general practice to respond to people who have depression. I mean, it's just brilliant, even though it may be a little bit undervalued. But it's been a great thing. So I think, yes, the resources are there. Some of the GPs do it and do it very well. Some of the GPs haven't quite chosen to go down that path yet.
Thanks, Ralph.
Thanks very much, Ralph. Tim, I believe you wanted to ask our psychologist, Prasunna, a question?
Yes, and I'm going to have to consult what it was. Now, we know that cardiometabolic and other aspects of physical health, of course, are entwined in this presentation and the presentation of, I guess, of a lot of people with mental illness, whether it be at the sort of primary end with the general practitioner up at the tertiary end. Now, you've mentioned the stages of concern that you might go through, and Bruce is pretty high. So the question would be, what particular psychological techniques would you find useful? But before you tell us, I think it was you, it might have been someone else, mentioning that it's very difficult when you're a solo practitioner. And if you are a solo practitioner and you're a psychologist, for example, how would you feel about putting a tape measure around someone's waist? Do you think that's assault? And I'm using that word with quotes around it. And this is a very important question. So can I put that then to you? How should a psychologist respond to the need for trans-professional awareness of physical comorbidity?
Okay, there are several questions you asked. Do you want me to address the assault issue and the tape measure and how people feel about doing that? I'm not in the habit of taking people's waist measurement in a psychological consultation. What I do believe, though, is that feedback is really important, and quite often when people are setting goals, and we're looking at how do they know that they have achieved wherever it is that they have achieved. Things like pedometers, the assessment process itself, being able to take a measure of weight or waist, any of these things that provide some feedback about where the person is relative to where they might want to be, and the way that is done can be very useful in terms of behavioral techniques. So I don't think it's assault, it's how one does it and for what purpose, and how that's built into the management of a person. I think pedometers are terrific and often help people just work out how to, what it means just to stand up and move around and walk around the house and so on. So in terms of feedback, I think that's okay. Let me talk about the trans-professional awareness, the physical comorbidity. I know that GPs who have good working relationships with psychologists are able to have that discussion about the physical complications and then psychological. I think in our training as psychologists, we have very little understanding of the physical comorbidities. I think we're terrific if we have a pure psychological condition. I think we can do CBT really well, and we know that that's an evidence base. I mean, in this case, I don't know, we might also be looking at some interpersonal therapies, solution-focused therapies, any of the evidence-based therapies. Problem-solving therapy works really well in situations where we're trying to deal with specific goals and specific outcomes. I agree with you that with comorbid conditions, if we can get people into a group, it has benefits and longer-term benefits than the individual therapy, because they often set up networks and understanding and role modeling and all those other things. Working alone as a psychologist, I think it's a real difficulty when all you get is a letter from the GP, or which generally says, could you see this person, they seem distressed. I'd like to have that conversation with the GP and say, tell me what you think is happening, tell me what medication the person's on, tell me what you think is the complicating factor, because that conversation will determine how I work with the person. And frankly, Tim, I don't think psychologists have enough training in our undergraduate years or even our postgraduate years in physical comorbidities. I'd like to see more of that brought in, and the conversations that we have with GPs, referral letters, and so on. I think we have better conversations with psychiatrists, actually.
That's good. Thank you very much for that. Now, Ralph, did you want to ask Tim a question? GP
yes,
asking a psychiatrist, thanks.
Tim, certainly I know you have a real passion around low prevalence mental health issues. And one of the things that always has amazed me is that there's been no position statement about what we should be using as an antipsychotic first line. And I was wondering, is there in fact a guideline that people use or psychiatrists use to say that in fact we should be using the antipsychotics that have a less diabetic risk, as opposed to ones that have high ones? So we know that certainly olanzapine has a much higher risk of causing weight gain and diabetes independently compared to some of the ones like risperidone and quetiapine.
It's a great question, and I'm probably going to give an answer you don't want to hear. After all this time, we've now got we track all of our patients in sort of minute detail, and these are just real patients, so I don't get much time with us, but we've got it all pretty well sort of sussed to get data very rapidly. Now, what happens at the end of our time with them, this is the psychotic patients, the endocrinologist and myself, and usually another sort of senior psychiatrist, we sit there and we put the whole thing together very rapidly, and we decide what we're going to do. Now, besides being sort of interested in, of course, endocrinology as well as neurosciences, of course, I spent 20 years as a psychopharmacologist. I know these drugs backwards. In fact, I've been involved in their development often with the drug companies. However, we don't change hardly anyone's medicine or recommend it to their own doctors, because it's the other factors in their life that are much more risky than the actual medicine. The actual medicine probably only accounts for about 12% of the developing diabetes for many of these people. So we're looking at their family history. So if we would go out and do a door knock, we'll find 15% of the population know someone in their family who's had diabetes or pre-diabetes. Every single person we see with psychosis, for example, has the likelihood of a 50% family history. We're also carrying about 48%, both in Melbourne and in Sydney, of people coming to the hospitals from the high-risk diabetes ethnic groups, where they only have to see the word diabetes and they get it. So then we've got to look at the general sort of trends towards obesity in society and so on and so forth. And all of these just general risk factors are much more prevalent than in causing the risks we see than the actual drugs themselves. However, and having been the sort of architect of the Australian consensus guidelines for diabetes and antipsychotics, for those that have read it, you probably realise that we sort of said in the end, it doesn't matter what antipsychotic you're on, you've got to screen and treat people all the time, every 6 months, the rest of their life, because the thing about olanzapine and all these antihistamine drugs that will make you fat quickly is that everything will make you fat eventually. And lifestyle, in the sense of not exercising and eating the really terrible foods that people with chronic illness tend to prepare for themselves, prepare I mean in a very loose sense, these are very much more important than the initial phase of treatment, where your risk from antipsychotics just depends on how much of an antihistamine it is, how much of an alpha-adrenergic blocker, 5-HT2C and 5-HT6 blockers. If I put all that together, basic pharmacology, it has an incredibly high predictive value for telling me who's going to get really fat really quickly.
Thanks, Tim. We'll just have to close that question there. We're rapidly running out of time, unless you live in Queensland, where we've got another hour to go before we hit 9 o'clock. I'd just like to ask, on behalf of the audience, I'd like to ask Catherine a question. And this has come through in the texting all evening. The fact that many of these patients, loners like this guy, possibly using amphetamines, long-distance driver, they feel overwhelmed by the medical industrial complex, for want of a better word. They feel that they're not listened to. They're often overwhelmed. How do you find in your clinics that you engage these guys? And I think Ralph alluded to this earlier on in his presentation about not going too heavy, planning to get them back, so as well as actually managing that consultation, you're looking at the next. Could you, Catherine, just tell us how you go about managing these patients?
Sure, yeah. Like Ralph, with great caution, I'm very aware that, especially if they don't come on their own accord, I'm very aware that firstly the physical issues are there and we need to help manage those things. So if this gentleman has blood glucose levels in the high 20s, I have to address that immediately. By the same token, you can't overwhelm them with too much information. So a lot of the assessment is on my part, but not necessarily, for the want of a better word, spew out all this information as such. It's more an assessment. And then the information we give slowly, and the information that he's ready to receive, and hopefully if he's got a family member there, he can cope better with the information, but also involve him in the process. So we're not trying to give him goals, that the goals are coming from himself. So most of the time, if you ask someone how do they want to live their life, they'll say, I want to keep on driving. I don't want to lose my legs, or I don't want to lose my eyesight. So they look at it from the perspective of their livelihood or living well with their family. So we need to look at things from a patient-centred perspective rather than a health professional perspective, because our perspectives may be slightly different, although ultimately we're trying to achieve the same thing. So we're trying to improve outcomes so that they can continue with their driving and so on.
Thank you very much, Catherine. And unfortunately, I'm going to have to sum up now. We're going to have to bring it to a close. I would love to spend another hour talking with everybody here and listening to your comments from the audience and your questions. This has been a huge webinar, a lot of stuff to fit into a short period of time. You've been an absolutely fantastic panel, such skill and also such humanity coming through from all the different disciplines. I think from Ralph we heard about This gentleman presenting, he was concerned he may have had some physical illness. He may have been substance affected. He was concerned about his adherence and getting him back. And he was also concerned that he may be suffering from a significant depression as a comorbidity. From Persuna, she exhibited her pyramid model very well, going through the different levels of concern, and was certainly willing and able to work in an interdisciplinary and disciplinary manner in managing this man, and also alluded to therapies that are not available readily, such as group therapy, and also the possibility that he may be heading into a major depressive disorder that may require more pharmacological therapy. Catherine, I think, gave us a very good illustration of the real-life problems that patients such as this suffer, fear of loss of income, and also the concerns that we have as practitioners in relation to his safety in his occupation as a long-distance truck driver. She also reiterated Persuna and Rob's concerns about his adherence and the issues of autonomy as well, the autonomy, but also those issues of justice that we all struggle with when we're therapists to people who are in charge of heavy machinery. And then Tim gave a very eloquent and skilled presentation, bringing together the bimodal associations, the need to treat depression, alluded to depression as being an accompaniment of all chronic illness, and then the roles of relieving that depression and improving chronic illnesses, particularly diabetes. And I thought his slide, particularly on telephone CBT and group therapy, certainly made me think about my management of my diabetic patients with depression, and certainly heading into as us baby boomers age and develop diabetes and get depressed, maybe groups will be the way to go, because it certainly will be much more cost effective for the community. I think the audience, it came through loud and clear that they felt that this man might be being over-serviced and not listened to, but I think that's just because we had so many services in such a short period of time to manage him. And it would be nice to think that his HbA1c has come down from 12 to 10.5 over the course of this webinar, but it probably hasn't. You really are a very skilled panel and a very, very good audience, and I certainly learned a lot from sitting here and listening tonight, and I'd like to thank each and every one of you for attending tonight. Thank you very much.
Thank you.
Thanks. Bye.
Bye.